Um, so we're here today. I wanted to give you a little bit of a story of why we're even having this conversation today. And a lot of it's been driven by Alyssa because she's been doing a lot of great work with our Age Smart project. And she comes back with stories from the field in terms of how Health Cities thought we were going to do something, and then we realized it's not going to work like that in the field. And so she's coming back and she says, "Well, we got to get a lot smarter about how we engage the individuals we engage in community." We also had a project. Many of you would know if you know Health Cities. We were doing a project around home health monitoring, Central Alberta, which was very successful. We kind of, as an afterthought, I have to be frank, we then went and talked to the individuals who received the monitoring equipment and wanted to understand how they enjoyed the program. Did it work? Did it make sense? Did they like the devices? We also had some preconceived notions of the kinds of feedback we got back, and some of that was in line, but we learned so much more than we ever thought we would, just in terms of the practicalities and how they were using the devices, why they thought they worked. It was not the reason that we originally thought. And simple things like that they had one point individual at the clinics that they could call whenever they wanted, and that person would pick up the phone was key. I'm like, you didn't like all the features? No, the fact that we could actually get a hold of somebody in healthcare and they would answer the phone, that was really important. So as we're expanding that program now, we're going across Alberta with that program. We know we need to figure out how to engage users, clients from the beginning. And we do not have that skill set. We actually don't even really know where to start. So there were some smart individuals who are in this room that we were going to call and have sort of a conversation with them around how should Health Cities look at this? Who should we partner with? How do we bring that in? And then another one of my team members had an idea and said, well, why wouldn't we just do this with the community? Because we could have this private conversation or we could have it with the Health Cities community. So this is why we're having this breakfast. We're going to learn about how do you engage patients in healthcare technology going forward. What are some things that we need to really consider? Where some things could go wrong? And some guidance, frankly, for Health Cities. But we wanted to do it in an open environment. So this is why we're having this breakfast this morning. So with that, I'd like to introduce Sandy Cossey, who is chair of Imagine Citizens. Executive board member. Sorry, Sandy. Executive board member of Imagine Citizens. There's some wonderful work that we're doing that ties right into this conversation. So, Sandy, over to you.
Thank you so much, Reg. I'll take the title of chair, but not yet. Many of you will know Stephen Samus, and Stephen is our board chair of Imagine Citizens Network. Stephen sends his greetings today, as does Don McLeod, who is our executive director. I also just wanted to acknowledge actually Leslie Ayer-Jaxie, who is in the room, right in the dead center of the room, who is also one of our longstanding volunteers and I'll say staff, because she's a volunteer. So Imagine Citizens Network is a long-standing Alberta-based volunteer not-for-profit organization. It started 10 years ago. 10 years ago, we're celebrating our 10th, or this year we're celebrating our 10th anniversary. Yeah. Grassroots, volunteer-led organizations, volunteer-led organization, passionate group of individuals that really saw the opportunity to bring the citizen, patient, lived experience to healthcare decision making and policy making. So that's something that we've been focusing on for the past decade, is the how to actually meaningfully involve citizens, people in the community, in our communities, and how healthcare is delivered, organized, funded, administered, evaluated. And we have been successful at doing so. So what started as a volunteer network, we now are able to partner meaningfully with certain individuals and organizations like Alberta Health in establishing some of the meaningful engagement and consultations around the Refocus Health System. We were also very instrumental in doing some work with modernizing Alberta's primary healthcare system and bringing the citizen perspective into our primary healthcare transformation. Our biggest priorities are primary healthcare as well as digital health. And on the digital health front, we've actually introduced and we've been working with Care Opinion UK, which started as a UK organization, or working with them about 4 years ago to bring Care Opinion to Canada. And we're successful at doing that now in launching our pilot project in primary care networks and continuing care. And what Care Opinion is, it's a digital platform that can create meaningful two-way communication between patients and care providers in an honest, transparent, collaborative, and safe and supportive way. So it's about creating honest conversations, it's about creating more transparency, and it's about really harnessing stories and experience to create meaningful opportunities for healthcare improvement. So figure it as you will as a virtual kitchen table or breakfast table like we're all centered around today. And it's the opportunity for bringing patients and citizens to that table. And so I'm delighted to be a part of the breakfast today. Thank you to Reg for the opportunity to address you, and we're looking forward to creating more meaningful collaboration with Health Cities. And of course, if any of you would like to learn more about Imagine, please feel free to reach out. We're happy to welcome volunteers, but also some collaboration opportunities as well. Thank you.
Thank you very much, Sandy. Thank you for supporting this morning's event and for your collaboration partnership with the Health Cities. It now gives me great pleasure to invite a longtime friend of Health Cities. Many of you will know Chris Carvalho. He wears many hats, but I think the hat he's wearing today is chair of Digital Health Canada. Okay, good. I got a nod. This is great. So Chris, come on up here. You're going to set up here?
Okay, I'm going to go up here. Thanks, Reg. Good to see everybody. I think I was joking around before we started here, and I think the last time Reg asked me to come up on stage was March 2020. So hopefully I see you guys. It doesn't take 5 years for me to get asked up here again. So really excited to be here. As Reg said, I'm currently the chair of Digital Health Canada, where patient engagement is a big focus of the organization, both from a membership perspective, but also from the education that we provide. Also, in one of the other hats I wear in the consulting side, a lot of the work that we do, many of those projects with Health Cities does have a significant patient engagement component to that, as well as engagement of other individuals that are part of that. So selfishly, I get to ask some very bright minds questions that will hopefully impact the work that I do, and based on what they shared in the pre-meeting, I think you guys are in for a treat. So to kick us off, and I'll ask each one of you guys to come up, do the awkward walk across the stage on your own as I introduce the facts. But first, before we get there, we all know that health innovation must work for the people that use it. That's why we're all here. That's why we're all in the business, is really serving the patients and those that are part of that care team. So patients, clinicians, communities, they all bring a different perspective. And too often, solutions are designed without truly engaging the people that it's meant to help. So today, we're going to explore sort of the process that might typically happen. What does meaningful patient engagement look like in practice? How do we learn from common mistakes and items that come up throughout that process? Then what does the future of patient engagement actually look like? And then how do we all build that into our organizations in a meaningful way? So to help me take you guys through that, I'd first like to call up Ursula Mann, so Chief Patient Officer at Patient Voice Partners. And again, do check out their bios, very impressive. But more importantly, Ursula is a mom of 2 kids and 2 dogs and loves traveling, and recently traveled to Costa Rica last summer on a health literacy. So curious to hear a little bit about that to kick us off, but please take us through that.
Okay, so is this on? You guys hear me? How's that? So in fairness, I did a reply all for the fun fact, and so I'm going to change it on the fly. Costa Rica was a good volunteer experience, but on my drive down, I was listening to the radio, and they did a poll of people rather, and the question was asked, what do you shake before you use it? So I'm going to let you think about that for a quick second. I was really interested to hear that the number 4 answer was inhalable medicines and medicines. So I thought that was really timely driving down here. Costa Rica was a great experience. We did some volunteer work with people that were out there, and it was interesting to see a difference in medicines and also how the health system interacts with people.
Great. Well, definitely looking to hear more about your experience from that patient perspective, so thank you. Next, I'd like to invite Heidi Dubiak, CEO of Canterbury Foundation, bringing that experience from that leadership and patient-centered care perspective. Heidi shared that she's actually run 3 Ironmans, which is extremely impressive. But I have to ask, your profile photo, the speaker photo, was probably one of the top, most interesting ones that I've seen. So can you give me a little bit of history on the bunny?
So I think it, for me, was representative of bringing a little bit of personality of Canterbury. Our profile pictures that end up on bios or on the website can be just very, it's my face and so what? And we have therapy bunnies at Canterbury. So Thelma and Louise are our therapy bunnies. We've recently learned that it's actually Thelma and Luis. We have a male in the house that we didn't know about. But that's one of our therapy bunnies. And it was really, when we did our headshots in true Canterbury fashion, we wanted to bring a little bit of our personality and our values into our pictures so people could get to know us and feel in relationship with us. And so mine was a bit of a representation of the organization, that when you come to Canterbury, there's a little bit more around the corner. So therapy bunny, that's Thelma.
That's great. Thank you. Next, we have Ben Millen, VP of Design at Tangent Design Engineering, specializing in that usability and med tech side of things. So Ben shared that he, not once, but twice, hiked 42 days all alone. So I'm sure he solved all of our healthcare problems and is here to share those with us today.
I was going to say it. I explored the full capacity of my ability to be alone, I suppose. I should have shared something maybe a little bit more healthcare relevant, but give me a lot of chance to reflect anyway.
That's great. Thank you.
So a bit of a background on Tangent, or how that's relevant. Tangent is a design and engineering consultancy based in Calgary. We typically design all sorts of things, I suppose, but medical devices among other things. And it's become important this morning to specify hard tech primarily. So physical devices typically that sometimes have some kind of a cloud or online presence, but physical things and physical interventions.
Great, thank you. And last but not least, we've got Dr. Ernst Gravenstein, so Medical Director for the Alberta Medical Association's Accelerating Change Transformation Team. But he's also a beekeeper, which I find fascinating. And he shared a comment around, the bees are more coordinated in their common purpose than maybe some of the organizations that he's worked with. So welcome to the panel.
Thanks, Chris. Thanks a lot. Really great opportunity for me to be here as well. I feel a little intimidated because usually when I sit in front of audiences, it's all healthcare providers, and so I really appreciate this opportunity with a different audience. Yes, I'm a beekeeper, and I also have 2 children. Sometimes my bees, they feel like children to me, 30,000 of them. They're sometimes sweet, and sometimes they sting as well, just like my kids. So I really kind of, just sitting with them and just kind of seeing how they work together and thinking how we can be more coordinated in healthcare as well. And so definitely lots of lessons learned from nature.
That's great.
I am the medical director for the Alberta Medical Association. My title is Health Systems Transformation, which is a huge title, and I've tried that for the last 25 years. I'm a family physician in Calgary and have worked in Africa, in Manitoba, and here in Alberta.
Excellent. Great. Thank you. So as you can see, some great experience. And I think when we talk about the engagement, we have different perspectives. So we have patients, healthcare system, the technology leaders, and then the clinicians. There's definitely more perspectives out there, but for the purpose of the discussion today, that's the hat that I think many will wear. But as with many of us, they may change their hats as we go. I think just to help understand who's in the room, maybe in those same 4 categories, how many do we have that are clinicians? Okay, and you can put your hand up more than once. How many are in the technology, med tech, startup space, vendors? Okay, great. Healthcare organizations, healthcare delivery, okay, and patients. Everybody, yeah, which we will talk about. So, okay, that's great. Now, in the pre-call, I think the common theme was, everyone has so much to say because they're so passionate about the area. So I did ask ChatGPT how to politely interrupt panelists. I don't know how they've been validated, but if you see me, slowly glance at I don't even have a watch, but my watch, and then stare at you, that means, time to let one of the other panelists talk. So hopefully we can have a discussion as we said, and please do jump in. I've got a bunch of questions to go through, but if anybody has something that they want to add, feel free. As Reg said, this is meant to be more of a discussion. We just happen to have 60 people watching us. So, okay, so to kick us off, let's start with that big picture, just to help with grounding everybody. What is patient engagement, and why does patient engagement matter? Seems like a fairly simple question, but I think based on the perspective that you have or the area that you're working in could mean different things to different people. So, Ursula, why don't you start us off? What does it mean to you from that patient perspective, and how do you ensure that it's meaningful?
It's a great question. How long do I have? Just
We've got till, I think, 12.
Perfect.
Right? Yeah.
Fantastic. And tomorrow, we're all sleeping over. I didn't share it at the beginning, but Patient Voice Partners is a life science agency. So as a consultancy, we're really a bridge to help support on patient, caregiver, patient organization, multi-stakeholder perspectives, and the healthcare policy and the fit in the space. And that bridge is really important. So we do projects with and for patient groups, not-for-profits, healthcare companies, government, and public sector. And one of the questions we often get asked is why, how, and what? So patient engagement is complicated. I would argue more complicated than stakeholder engagement. With patients and caregivers, there are additional privacy considerations. There are groups we're not tapping into. There are patients and caregivers that would like to stay private and anonymized. That's one of the reasons we do some of the work around the projects. So patient engagement is ensuring, first and foremost, you have the right voices around the table. And what I mean by that is, what is the profile of your expert? Do we want to have somebody that has an oncology experience be put in a position where they have to comment on what it's like to have a chronic disease? That's not the same. And so there's a lot of considerations that go into who do you want to hear from? How are we finding the right people? And how are we engaging them? It gets more complicated with health literacy and some other factors in content creation, but that's some of the starting factors, is without making assumptions, what do we want to learn and how are we going to go about doing that?
Great, thank you. Now, Heidi, same question to you. What is patient engagement, and why does it matter? But if you could bring that lens from the leadership and organizational side and how that factors into decision making.
Absolutely. So I think one of the key things that we've had success with is the idea of co-creation. And if we're co-creating a community, an environment, that means we're starting right from the beginning, engaging I call them stakeholders, but our residents and families. I think that's intuitive, and people are like, okay, great, start from the beginning. But what gets in the way oftentimes, I think, in organizations is a fear of what can of worms are we opening if we allow that voice to just come out right from the beginning, and how do we manage that? I just really would encourage, when we think about what it is, I want to just kind of peel back that barrier of please lean in. And trust that will turn out. Trust the process, and trust that you'll be able to manage the conversation and have better results, even if it feels big and messy. And you may not deliver exactly on everything that the family or the resident thinks they want or needs, but bringing them along in the journey, and you'll hear that in the discussion today, will result in a better outcome for all. And so just don't be scared of engagement.
Great.
He didn't look at his watch.
Not yet.
Whew, we're doing good.
Ben, so same question, but from that design perspective, how does it actually impact the development of health products and services?
Yeah, that's difficult to follow. I think don't be scared of it is a perfect message. Words are interesting. Patients, can be viewed in our perspective as users, sometimes a secondary user, so somebody that the device is or the technology is kind of being used on, stakeholder oftentimes as well. I think the primary message from the development of new technologies and that sort of thing is to try and involve people as often as you can, to try and ground the assumptions that you're making as a design team, or as a designer or somebody who's trying to bring a new technology into the world. It's very easy to kind of have an idea and keep that very close to you and sort of be precious about it as you're developing it and trying to prototype it and get it to a point where it's ready to enter the world. the tendency is really to kind of like hold that close and not touch base with people who will actually be using it or be interacting with it at some point. So again, very much the same, right from the beginning around the question of like, what are you doing, or how are you approaching the design problem, or how are you approaching this intervention from the beginning, involving or engaging people about what the problem is, and then all the way along, sort of through the process, trying to touch base with the users and the patients to see if you're on the right track, if the approaches that you're taking are landing. What concerns they might have, or what input they might have as well. So very valuable to sort of make sure that it's a successful technology in the end. He's looking at me, so I'm going to end.
Great, and Ernst, so anything else from that clinician perspective that we haven't touched upon?
Yeah, so I'll perhaps kind of approach this from my own personal experience as a family physician. I mean, I need a patient to be engaged in their healthcare. I'm not going to be able to tell anyone to do something if they are not fully bought into what I'm trying to kind of convey to them. So I think, and if you kind of take it from that perspective, as basic as it is with that wellness in mind for a patient, and you extrapolate that into what we need at the system level, it's exactly the same. We need patients to be involved. I struggle with the word patient because of the passive nature of that. There's some really good examples of what's happening in other countries, and specifically in Alaska. There's a place called Nuka where they have the Southwest Health Foundation, and they call the patients customer owners, and wellness owners or wellness partners, I think is a term that I think really kind of provides some ownership to people in the healthcare system. So. I think, the fact that we're still talking about patient engagement and it's 2025 is really, it's challenging for me. Shouldn't this have happened in a publicly funded system specifically as well? If you think about when we look at the globe, there is not enough healthcare providers to provide the quality care that patients need at the moment. So we're kind of starting to think around team-based care. And who's at the center of that team? That's a patient. And so how do we involve that patient in the team that they need and build communities around those patients in order to support them in their wellness journey? I think so is foundational to the future that we would like to see in healthcare.
That's great. So to build on that, and I think when you raise the term patient, and there's other ways of looking at how we classify any of the individuals, but it's important. I think everybody agrees to that. But why is it taking us so long to incorporate that into just daily practice? And whoever wants to start, yeah, please.
Ownership. I think, and I'm a clinician, so I can easily say this. You know what? The system was designed around us, and the system should have been designed around the patient, the person who received the care, and as I previously mentioned, it needs to be flipped around. So grassroots initiatives like Imagine Citizens, Care Opinion, those kind of initiatives that actually inform how the system should be built. I think the sustainability that would come from that is significantly better than what we see at the moment. I'm going to speak honestly. We every 4 years we see a different priority, and unfortunately, primary care. The results that you see in primary care is not going to be realized until 20 or 30 years from now, because it's screening and prevention. And how do we engage patients and the communities in screening and prevention exercises that's going to actually have sustainable outcomes for them in the long term?
Okay. Ursula, yeah, please.
Yeah, I'll build upon that. I think in a word, it's complicated. We've done a number of projects where we're not just asking the question, we're not just content creating, we're not just saying, what's the surface level reaction to people's responses, but what are their feelings, beliefs, and desires? But we've actually had to take a step back before we get to that question and say, and this is true of people that are very sophisticated, and say, before we ask you this question, before you give us the answer, what does this question mean to you? And at times that we've done that, the answers have been very different, wildly different interpretation. Well, the problem is, I'll take aging at home as an example. If people are inputting their own data, but they're answering the question differently from a different lens, that impacts your data. So complicated is very different on the health literacy front. There's also privacy considerations, which are a little bit different as well. And so there's a lot of considerations that bake into what that really means for people.
Great. Heidi, Ben, anything else to add on why we aren't doing it, why it's difficult?
Yeah, maybe from the technology point of view, it has been, or it is, or seems easy to defer. Compared to some of the technical challenges that you might solve or try and solve from the engineering perspective to try and bring something into the world, those seem very sort of present and difficult as barriers, and it's easy to push off user testing and some of the what's considered softer aspects of a design or a new technology to the end, which is often too late, or often at the point where you're about to launch the product and just say like, okay, well, the users have to deal with it now in its current form.
I'm maybe going to say something really obvious about it. A new option hasn't been introduced. Naming, nomenclature is really important, and there's not a common. So if it's not patient, what else is it? And thank you for introducing some new language to that, because I don't know that there's been a commonly accepted something else. And therefore, when we're talking, an industry or, describing something, that's the only description word that exists. And so I think just having that conversation about what should it be, it's an issue, and B, we need a new word for it. I think we need to start talking about it. So it's, I think, something to consider for all of us is if it's not patient, what is it? So that we're then able to I'll use a common language, because right now when we say patient, everyone understands conceptually what that is.
Right.
And if it's a different word, we get a lot of, even the patients themselves get very confused. My environment, we do things differently, but words that other people are using is confusing, right? If you are defining things differently. So we need to think about what a different word is.
Yeah.
Can I add one more quick thing on that? So
Yes.
That's a really valuable point around words matter. There was one project, we asked people, are you a patient or a caregiver? A number of people said, I'm not a caregiver, and they selected other. But then when you looked at the responses, other was spouse, child, friend, partner. They could have been classified as a caregiver, but they didn't call themselves that. So sometimes it's persons with lived experience, but people said, well, they're not dead. So it's persons with lived and living experience. So words matter, and there's some differences around what that can mean to different people.
Great. Ernst, please.
One of the great examples, and this community, or actually county in Sweden, called Young Cupping, they often present at quality improvement seminars worldwide, and that's a community that has actually done exactly what I said. They turned everything upside down. Community is actually rallying around people. They use technology to build continuity with specific care providers, but they use a patient's name. So what would Esther need in this situation? So there's an actual name to the individual who is going to receive the care, and you can use any name for that matter. But definitely, I think that makes it more personal.
Great. So all great examples of how we can start to think about patient engagement in a different way. What I'd like to do is dive a bit deeper into some of those common mistakes, just to help set the foundation for moving forward. So, Ursula, you've already given us some examples, but what are some of the most common mistakes that you see in the patient engagement process from that patient perspective?
Yeah, thank you for that. I think it's a bit of a lack of recognition as to when to start, and that it's ongoing. There's still some tokenism, there's a tick the box. Ironically, I was chatting with somebody who is a patient expert, and we have a patient advisory board coming up. We're in charge of patient finding and connecting, which we do with Patient Voice Connect. And he said, well, we don't need to ask patients. We already know everything. I've done all this work. We know everything, which took me aback a little bit. The reality is we learn very specific things which change the course of care for people. Everything from patients disagreeing with how severe their disease is. that has huge ramifications because you know, based on drug label, if you're not severe, this is not a treatment option for you. That's off the table. So love the technology example as well. There have been many examples, startup, amazing development. It's fully baked and then it goes to the patient. Clinical trials, completely finished, had the wrong patient reported outcomes. Patients are like, we don't really value that. We wanted this other thing measured, and then that impacts regulators. So despite it being complicated and despite you needing a bridge, you need the patient and caregiver perspective, but also the understanding of how are you integrating? What are the goalposts? Are you changing the healthcare system? Or are you integrating a healthcare system? There have been examples of, and I'll call it failed projects for lack of a better description, but amazing patient caregiver input totally changed the project. They got to the very end and it all was unusable because it couldn't integrate into the system. And they didn't have a partner at the beginning that thought to ask, how are we going to be using this? And so for those reasons, you need both. You need the partner that understands the system and connects with the patient caregivers. You need to do it very early on, despite budget and time constraints, and throughout the process. And you need it ongoing. So those are some important considerations.
Great. So Heidi, as one of those partners from that organizational perspective, what are some things that you've seen that help improve that process?
Yes, excuse me. So I think I have a really nice example from just the past few weeks. I had an opportunity to sit in front of a tech startup, and they wanted to kind of demonstrate this AI-powered product, and I was like, okay, great, but now I'm trying to figure out how this is going to work. How is this going to work with my resident population? Are they going to engage with it? And then what does that mean for my clinicians, right? Is there an ROI? And so when we're designing this, we talk about stakeholders, but there's also outcomes, right? We need to have critical mass from our residents. We've heard this idea of they need to engage with it. So the whatever we're now going to call them, I'm going to keep calling them residents, family members need to engage with this. Otherwise, we have this thing over here that's kind of happening, maybe kind of not happening. And from a business perspective, right, as you're trying to design something and bring it to market, there has to be an ROI to it, and there has to be an ability to have enough uptake that we can standardize this. So bringing that lens to it, where I need to be able to understand how are we going to integrate this in a meaningful way, is really important. And so the other side of that picture is, and I want to just acknowledge Team CarePal, who's here today. I just had a session where we're on the front end engaging our residents and families. We've had the opportunity for them to pilot it, get feedback, and look at this from what is our resident and family population telling us they want from this, and then what is the opportunity for the business that creates clear return on investment or an outcome that's desirable for us, so that we're marrying those two things together right from the beginning. So that's, I think, the two ways that this plays out. You either develop a product and then try and hopefully fit it into the market, or you start from the beginning working with your desired market.
Absolutely. So maybe Ernst, look to you next to follow up and comment on that, because as you're working with the patients, but you're also doing your job at the same time. How do you balance the input and importance of the voice of both of those players in that relationship?
Yeah. So, and again, at the face level with my patients, I mean, shared decision making is what it's about, and how do you convey certain health benefits to a patient, but then also get buy-in from them in order to adhere to some of the recommendations. I think, and the challenge that we've had, and so I have the I'm fortunate because I work with undifferentiated patients. They come to me, they have biopsychosocial kind of concerns, and I need to kind of sift through those in order to make some sense of their medical condition. But I also need to take everything into consideration. A cardiologist might decide, this is the stent I'm going to put into a patient's heart. It's one of two options. So with the undifferentiated care that I have, I think the view that I have on patients, their decisions that they need to make, and how to get buy-in from them is much broader. And I think, and so from my perspective, when we kind of design system outcomes, we only look at it from a system or a medical perspective. And if you look at patient-reported outcome measures and patient-reported experiences and build that into some of those measures that we currently have, that will go much further. The examples that I've seen in the past of absolutely meaningless engagement has been to just report on certain measures for reporting's sake. And patient experience is one of those things that we as primary care networks had to report on for multiple years. The time, the effort, and the energy that went into it has been really, it's been a waste. Whereas, however, some of you have been engaged in that, the Modernizing Alberta Primary Care System, and how patients were actually involved in planning that together. One of the, and I think the momentum that is built from having patients engaged in that is much stronger, and is going to also bring it much further as well. I would like to go one step further, however. I would like patients to ask for the change and for them to spearhead the change, and that it doesn't come from either government or from physicians or healthcare entities. And I think that is going to probably lead to much longer lasting and sustainable healthcare change.
Yeah, great point. But how do we, we talk about literacy. It's using the system, it's navigating the system. How do we best prepare patients to be able to ask those questions so they know that they should be part of that discussion? And that's to any one of you to kick us off.
Okay. I think it's coming. I think we've seen a real change. Back many years ago, it was the case where patient went to physician and the patient would say, what should I take? Now we have social media, we have Dr. Google, we have patients looking for information and wanting to come to the table. There's big movements with patients wanting training on healthcare policy and how do they get involved in decision making. And I feel like that's growing. It's a little bit of a movement. So then patients hear from other patients and then they get involved in that. I greatly appreciate the comments because I think sometimes there's a little bit of nervousness, and that's been talked about earlier. There's a bit of nervousness. What if we hear what we don't want to hear from patients about our products? But we never say that about healthcare professionals. We never say, what if they tell us they don't like this? What are we going to do? We're going to react to make it more appropriate.
They don't tell us they don't like it, do they?
Well, I think all feedback is important. And so to be able to embed that and bring it around the table and continue to support those opportunities and make sure we have current experiences around the table is really important.
You haven't had a chance to jump in.
Yeah. And I am curious, Ben, too, like at the end of the day, a lot of the work that you're doing is working with companies that are trying to build a product and get it to market. So balancing all this activity that's important with getting to their end customer. How do they do that in an efficient way?
Yeah, I mean that's a great question. In terms of the different approaches and different times that you do that. Again, I'm going to end up repeating myself into saying the worst possible thing or the worst possible outcome is to wait until sort of the end when you have a functional prototype or something like that. But I think it's really important to use a variety of methods early on, and in particular not be too deterministic about the kind of confirming your own ideas. One of the big problems that I see is people going out sort of with their own idea or with their own product and trying to sort of run a study or an ad hoc study on their own. Which ends up sort of in that space of just kind of confirming, what you, or trying to confirm what you already think you know. So using a third party, or having others do that work for you so that the conversation can be much more open, so that it doesn't feel personal, so that, the patients or other people are feeling willing to sort of like provide objective feedback about sort of what's going on. I think that's important. The other thing I would say is, there's a tendency towards sort of feeling like these need to be, like really big, thoughtful and onerous studies all the time. And in some cases they do because of sort of ethical considerations and so on. But there's also a lot that can be gained through ad hoc methods, informal conversations, sort of finding people where they're using products or similar products, or in the workplace or something else, to have a series of conversations that can help inform those things.
Great. Please, Heidi, go ahead.
So I'm going to introduce a concept, and I think it's here. How do we get patients? I feel like I need a new word. How do we get individuals to ask for this and call for this? So I'm just going to sort of say to everybody, I've gone on various different apps or online features for organizations where you're trying to navigate, checking your bill, wanting to change something in your account, and it's not working, and there's literally no way to connect with a person or to, it's like there's this dead end of like the app is over here and they want you to be in IT land and not interface with a person. The magic here is that, especially in healthcare, is that, and if we want our patients to engage with it, is they still need to feel like they're in relationship with us. And Reg said it at the beginning, right, where one of the most valuable pieces of the technology he was speaking about was that at the end of the day, for the patient, the thing they learned was that they could call and get in touch with someone. So yes, I'm willing to use this technology. I see the value in it, but it can't be over here. So when we're designing and thinking about it, the message that I've heard very clearly, and our residents and families are calling for it, but what they're asking for is the ability to interact with us, to be in communication with us, that there's a relational, personal component to it, and that can't get lost in the design from the user level. And one of the things we talked about in terms of having patient engagement at the table in our pre-session was this question of like, well, if we're all patients, someone said that we're all patients, but if you're wearing your hat of developer or innovator or visionary at the table, are you able to properly wear the hat of patient at the same time? So don't make that mistake of missing the fact that what hat are you wearing, and are you able to wear multiple hats well? And do you need to really bring in someone else to give you some feedback early on?
Yeah, that's a really important point. And I think when we think about the multiple hats, or maybe the positions that some of us are in to influence the change in these things, there's probably lots of people in this room that may not be in that position. So what advice do you have for the audience where if they're witnessing some of these common mistakes, how do they frame it in the way to start changing a very complex process or system? What advice would you have to get started? And we'll start with Ben, because from a product side, maybe that's a bit more straightforward.
Oh, geez. I feel like that's an institutional question. What advice to get started? I think I'll sort of reiterate what I just said, which is to not be so encumbered by it, not be so pressured or so concerned about the preciousness of the ideas, and just to start effectively as informally as possible. I think just to follow on that last point, involving people early in the question of framing the problems is really valuable as well. So, starting from a position where you're trying to kind of implement a technology and introduce it, and the whole thing is happening sort of for that new technology's sake, can sometimes be a problem. Stepping back and sort of returning to that space where you're thinking about sort of like, what is the relationship, or what's really important about this relationship or this interaction, and trying to figure out sort of like how you're going to approach the problem, and doing that early is a good place to begin, I suppose.
Okay, maybe Ernst, to dive into that a bit more. How do you balance those two perspectives, right? It's getting started from the patient perspective, but then also how does that impact the clinician's workflow, and keeping those both in mind?
Yeah, and I think, obviously, there's a culture shift that needs to happen, that we know who is driving the change. And at the moment, as I say, it's very clinician focused, and if we kind of turn that around, then that would be actually patient focused. And if my patient wants something, then how can I deliver that? I think I'm just going to kind of touch base on the literacy part as well, and just as a sociology kind of concept is that for sustainable change, people need worldviews, institutions, and technology to align. And when it comes to specifically to healthcare literacy, is where do we get our information from? It's even challenging for us as clinicians at the moment. I mean, we need to make sure that whatever AI search tool we use is searching it from a specific source, and that those sources are listed. And at the moment, we know that Google is a very popular doctor, and how are we able to perhaps provide a platform or create a platform where there is meaningful information that is relevant to patients and that is accurate, and that it is also relevant to a certain environment as well. And so is something like an Alberta-based patient search engine regarding healthcare an option? Is a triaging system that we have, that currently we have HealthLink, for instance, that triages patients. But is there a mechanism that an AI-supported triaging system could direct patients to the right information, receiving the right care at the right time? And that doesn't necessarily always involve a provider. So there is definitely a literacy piece, but there's technology that needs to support it. And then I also want to say is that, I mean, one thing that we've recognized with social media is it didn't bring people closer together. So is there technology that is actually able to build that network around a patient in order for their worldview to be supported and to be changed in order for them to have a wellness perspective? And how can we kind of foster that as well?
Great, thank you. So we know it's important. We've heard some common mistakes. Now looking forward to how we actually start to overcome these barriers and engage in a meaningful way. Heidi, curious to know what your thoughts are on healthcare leaders and organizations and the role in ensuring that engagement is both meaningful but also sustainable. In the pre-call, you shared some examples of how your organization does that with some of the committees and groups. So curious if you could talk about that a little bit more.
Sure, and I am just going to quickly add to the previous question to say that I think one of the meaningful ways is validate, even if you want to hold your product precious, we get that, validate the pain points. Validate the problem you think you're trying to solve with these groups is my advice. Even if you don't tell them how you're going to do that or what you're thinking, make sure that you're trying to solve a problem that is meaningful and aligns with all of your stakeholders. And then moving into, okay, so how do we do this thing called patient engagement in and I used the word early on, co-created fashion, for an organizational perspective, and maybe this applies then to the tech startups and the designers. What we have done is include the voice of our residents in really key and critical areas. So, oftentimes there's resident councils and we get feedback there, but we've gone a step further to ensure that those voices are on I have a resident and a family member that is voted onto our quality committee at the board level. So we're hearing from our stakeholders. My board hears from our stakeholders on a regular basis, and every whether it's town halls, we are really, it's embedded into our mission, vision, values, and what we're called to do is to ensure that at every step of the way that voice is there. It has to be grounded in your values, in your organizational identity. Otherwise, it's really easy to miss it.
Great. Now, Ursula, you can build on that, but I am curious to know a little bit what we talked about in the call as well, is getting patients to the table to have that discussion, and specifically, should we be compensating, or should patients be compensated for their time?
That's a thoughtful question that comes back to the complexity, because for decades, if it happened that a patient was at the table, sometimes there was a 16-page legal contract to sign, but they're like, well, just volunteer. We can't figure out how to pay them anyway. But I think, to speak earlier to the movement of patients' caregivers, that's changing. There are fair market value calculators. If we're compensating other stakeholders, we can and should be compensating patients and caregivers, and there are compliant ways to do that. I think that speaks to the respect piece and also not making things tokenistic. So we want to make sure we have the right voices around the table. It is a culture shift. I really appreciate that language. I think the starting point is for organizations to understand, groups, whether that be product or development, what's going to happen if we don't hear from, what are we going to be missing and what's going to happen. The what and how does get easier. Yes, we're going to engage patients and caregivers, but why are we doing it and what are we going to learn? And as we get more examples as to what we learned and what changed, which is happening in some global conversations, I think that's really interesting. The one thing that hasn't been mentioned is there is patient and caregiver burden. And so people get too many surveys. That's important. We have to factor that in and consider it. We also have to ensure that not everybody has to stand on the table and announce what they have. So people they want to share privately what's happening. And so that diversity of voices is really important, and that respect factor does play into fair market value calculators and ensuring people are not just contracted, but they're compensated. And I take it back to the profile of who is the expert that you want to speak to, and have we heard from them? Are we missing any voices around that table?
Great, thank you. So importance of finding the right compensation and models, but the reality is that we're in a resource strapped environment. The healthcare system's accused of moving too slowly when it comes to innovation. This process is, as you guys have said, is complex and important, but how do you make sure that you're getting the engagement that's required, but also keeping up with the speed of how fast our ecosystem and sector is moving? And I don't know who wants to take that one to start, but maybe Ernst will start at the end and work our way this way.
Yeah, Chris, so I'm going to perhaps answer this in a roundabout way. Coming back to the barriers, and specifically the barriers that we currently encounter, there is no systematic way of patient engagement, and there are really good examples of things that are being developed. I think Imagine Citizens, other patient opinions, and then Care Opinion is one of those. So I'm going to kind of just explain a little bit about the platform itself and how that can help with overcoming barriers. So Care Opinion is obviously a moderated way for patients to provide feedback, and then a closed loop back to the patients in order to see the changes that has occurred based on that feedback. Great concept. The challenge that I have as a provider is majority of the concerns with healthcare is not related to the provider, it's related to the system. So then if you have that closed loop kind of feedback mechanism, how do I as a provider kind of change system challenges? And that's, I think, where Care Opinion is very valuable, because you can start theming common concerns for patients as they encounter it through the system, and then use those themes to advocate for system change. And so I think the reluctance that people currently have in regards to kind of engaging patients is just, I don't know what I'm going to do with that feedback, and can I actually make a meaningful change? And so we do require some system level commitment in order to make some of those changes happen. So with that being said, I think, yes, you know what, I mean, it is going to continue to be an adjustment for physicians, for clinicians, as well as for patients, in order to make sure that we are able to, for one, get meaningful information engagement, but then also be able to act on that, and also to see the system changes based on that.
Okay, great. Others, comments on?
Yeah, I suppose there's a bunch of different ways from my perspective to answer that. One of the great things over the last few years has been just the level of comfort with digital platforms and technologies for collaboration and connecting with people. So being able to connect over Zoom or Teams or something like that, or to have a focus group of some very specific individuals and to facilitate that discussion using something like Miro can be very powerful, where previously you'd have to bring in a number of people. The other thing, I suppose, just on the front of kind of keeping up with technologies, things are developing very quickly. Things are changing. The amount of time that it takes to get something to the market is quite long by comparison. So something that we sometimes feel or find valuable is to test what we would call works-like prototypes. So something that can be just kind of, I don't want to say thrown together, but put together very ad hoc, that may not look like a finished product, but can act as a proxy for the experience of using that technology in whatever raw form. Gives you a chance to kind of simulate that interaction or how it might go with open-minded individuals, hopefully, and sort of test what that intervention might be like, before you kind of go down the road of full product development.
Yeah, so I don't know if anyone's noticed, but healthcare in general is really good at doing the same thing we've always done because we've always done it that way. And so when we look at things like, we know the adoption curve exists, and so how do we create points of leverage in the system? And I'm going to kind of throw it back to the fact that we're all here today because of Health Cities, connectors and innovation arms in strategic places in government or in our environment really help pull us out of our day-to-day operations when we're really busy doing the thing. Looking after patients can be all consuming, running an organization can be consuming, and we need to kind of be pulled out of that in a very intentional way to have these conversations, to think about where does innovation fit and how does it fit. And I think that's the importance of having an intentional strategy, whether that's at a government level or at an industry level around technology, because otherwise we just keep doing the thing. So these are really valuable opportunities to have the technology introduced to us and look at what that could mean. And I think that's one of the ways to actually develop some catalyst around this.
Great.
So I shared with you at the beginning, what do you shake before you use it? And I know you're dying to know what the number one answer. This is Edmonton Answers. So any guesses as to what the radio said was the number one answer, not health related? So salad dressing, then dice, then ketchup. But I take it back to medicines was number 4. You shake it. So in Edmonton, there's a lot of experience. I think the comments around keeping up with the speed, because I was intrigued, actually, health made that list. I wasn't expecting that when I was listening to this on the way down. But I think co-creation is really important. And I think finding those examples where we can actually save time as a result of better stakeholder engagement. There was one example where patients were properly consulted on patient-reported outcomes preclinical trial, and the trial was ready to go. They realized in the pre-consultation that they needed a specific test from the patients to enter the clinical trial. Fortunately, because they talked to patients, they said, by the way, we already have that in our chart. The results of the test never changes. I don't want to have to redo that test. It was kind of a long test to do. The clinical trial was changed. They saved 3 months. They're like, never mind, show us the results of the tests and come on over. I think that's fantastic. So I think that there are ways to figure out wins, to move things along, to keep up with speed and continue that continuous feedback loop.
Great, thank you. Well, I haven't given the sign that it's time for a question from the audience, but I'll give you guys a minute to think about that, and I will call you out by name if there's no one stands up. So before we do that, I have one final question, and it's dedicated to my son, because when I was preparing for this, he came over and asked, "You're going to speak. What are you talking about?" So I was explaining, what is patient engagement, how it fits with our work, why it's important, making sure everyone has a voice, all those things. Then later that night, my wife and I are talking about something, and he's like, "What are you guys talking about?" And he wanted to give his opinion. I was like, "We don't have time for this right now. Like, kind of go." And he's like, "I bet you if I was a patient, you would listen to me." So, with that being said, I got to ask each of you, and you can answer in a sentence, and then we'll get to audience questions. But should patient engagement be mandatory for all innovation projects? So, Ernst, we'll start with you and work our way this way.
I would say absolutely yes, but I would actually like any innovation to be driven by patients, and then that is a non-issue.
Ben?
How do I follow that? Yeah, exactly. Yeah, no, absolutely. My answer would be yes as well. And again, we're governed, thankfully, by regulations that usually tell us that we need to do that sort of thing. So.
I wouldn't be here today if I didn't believe that, and I don't love that has to be governed by regulation. It feels like the right thing to do, and if we haven't convinced you of that today, we haven't done our job.
Yes, and we also need multi-stakeholder engagement. If we put patients and caregivers in a situation where they give us pie in the sky ideas and those pie in the sky ideas are not implementable, we're back to tokenism and we're not moving the needle forward. So yes, and having multi-stakeholders around the table to get diverse points of view to not only make it better for patients and caregivers, but also have it work in the system.
Great. Okay. Thank you. So we'll open it up to you guys. And someone's going to come around with a mic. John.
Hello. Oh, there. Yeah, John Sproul, Institute of Health Economics. So I'll ask a value question or a cost question, which I think is important to this discussion. I totally agree with Ernst around the NUCA system, which I think is fantastic. And one thing they did was they privileged behavioral services much more than medical services, actually, in a lot of their work. And it speaks to what's the basket of the promise that we provide Alberta or Canadian consumers of what the government is going to step in and cover. And I think a real dilemma is not having a discussion on that business model. It's dominated by historical kind of segments. But as we move into things that might improve your wellness, I think you can't expect government or public shared resources to fund all these great new things. So there's going to be a mix. And so I think that's a real dilemma for us as a society of deciding what's in and what's out and getting consumers to buy to that new promise. And so just wondering around that scope, and Ernst, I won't want to put a thing on doctor, but sometimes physicians are the most resistant to giving up certain territory. And as I worked with a former Minister of Health, everything seemed to be add-on, and most other departments feel if they went to a cabinet table, they're going to be having to give up most of their budget every year to health because of that great sucking sound that comes from the health system. And resources might actually be needed to improve wellness that isn't actually in the health system. But that whole idea about defining the basket is, I think, just some comments on that so the public knows what can they expect.
Thanks, John. That's a very loaded question, and I'm going to do my best with this. I fully agree with what you say. I think the challenge that we have, and so what we're doing is we're building a healthcare system on a very weak foundation. That's the challenge that we currently have. Screening and prevention is the number one thing that we need to do in order to have better health outcomes for the future, and we haven't invested enough in that. I fully agree with you. It's not a government responsibility necessarily. It's a community responsibility. And how do we engage the community around that? I also agree with you that we need to kind of think about the economy because technology moves us ahead and we have better patient outcomes because of technology with certain conditions. The cost, however, associated with that new technology and the incremental benefit to the population is disproportionate. And so we need to reimagine that, and I fully agree with you. I think, if I have my perfect world, I would redesign, and this is kind of where Health Cities comes in, I would redesign communities and have communities own medical centers. And those medical centers actually have influence with the local schools. And that community rallying around patients, supporting them psychosocially in order for them to kind of, as a community, be healthier. And by building healthier communities, you build healthier cities. But that is a fundamental shift in what we're doing at the moment.
Ursula, please.
Sure, I can build upon that. So it's a really good question around cost. We need to be able to pay our bills on the system to work. I think there are times when we make the assumption new treatment is available. Are we budgeting for 100% of patients? There was one situation in an area we asked patients, would you take this tomorrow? And it was about 20%. Well, 20% is not 100. That's quite a different cost. So there are times we need to figure out who is the actual market for, and this helps in the cost. Switching hats, there's another hat I wear as a not-for-profit support founder with Towers. And as we look at new systems on cost and long-term, we're able to track with patients and physicians, providers, payers, policymakers, and producers, are patients still responding? And if they're not, Many patients are saying, I don't want to be on something that I'm no longer responding to. And is that a cost savings? So it's not just the upfront question of how much does this cost and are they going on it? We also want systems in place to look at it years later to say, is this still efficacious? And does this continue to make sense?
Great.
Yeah, I'll just, I want to build on what you've said. I think so Canterbury is a bit of a microcosm for that idea of community and what that can be. We're located right across from a junior high and elementary school, and they're integrated. And when COVID hit, what we did was sort of put up a shield where it was like, okay, if we internally protect each other, we have a fighting chance here. We don't know what this thing is. And we got through COVID as a facility, as a seniors care facility, with no outbreaks and no hospitalizations and no deaths. We had a little bit of an outbreak when Omicron hit, because that was just Omicron, but there was vaccines in place by then. So we were incredibly unique in that. And I will tell you 100% of our success was around engaging families and communities to understand that, and it was the exact opposite as what I saw happening in the province, which is I have rights. I don't have to wear a mask. I don't have to. I believe personal rights. And we created a strong sense of community and relationship with one another, and a sense of, if I'm not doing this, I'm potentially putting my neighbor at risk who is immunocompromised, and that matters. And so I just tell that story because I think it applies to, now we use that in terms of social engagement. Like, this is so now it's the social prescribing of not being isolated, getting out and getting exercise, and doing those behavioral things that contribute to better outcomes. In addition to, we have primary care right in our facility, so we're doing the prevention and screening, but adding the healthy behaviors on top of that in a supportive environment. So we have kind of created that in Alberta in a very small little way, but I think that's where the opportunity is to grow that. And we're trying to, at Canterbury, demonstrate that model to government to say, this is the opportunity, this is, how we're able to potentially save some of those healthcare dollars in the acute care side by investing in the right things happening at the front end.
Great. Ben, anything else to add?
Very little else to add. I don't deal with public funds in many ways, but I suppose from our perspective, we're constantly advocating for the potential return on any particular investment, and that's sometimes a useful way to view things.
Great. Okay. Next question, please.
Good morning. Thank you very much. I'm Laura Pinchbeck. I'm a professional human ecologist, and so I focus on the relationship that people have with their material environments in order that they can be well. And one of the things that has been running through my head all morning, and nobody said it, is the mantra that we have adopted from the disability rights movement, which is nothing about us without us. And we add the clause in that, which is that it's nothing about us without us in the way that works for us. And so in other words, we can't ask professionals to impose upon patients, families, and caregivers how we want them to be engaged. We want folks to be able to say, this is what's going to work for us in terms of providing that feedback. The other thing that comes to mind, and I apologize because even though I'm have an academic background, I don't remember the name of the article, but there is a recent article that came out 2024 looking at 4 different types of experience. So that's not just lived experience, but also loved experience, labored experience, and learned experience. And so in our work now, we're trying to be able to articulate how people are coming from those various perspectives to be able to do that. It's not easy work because it means people need to be able to identify their own agendas and to be able to be honest about why they're coming. What I want to ask you folks is, what kind of training and what kind of expertise of understanding how to perform and realize this engagement are you asking your colleagues to do when they don't have a background in this?
Yeah, great question. Training to help with this process. Who wants to start? Maybe from a technology perspective, then. You might have some.
Yeah, that's interesting. I work primarily with engineers. I won't take up too much airtime. let's see, what can we say about that? I mean, like certainly having people that that are trained in various research methods is incredibly powerful. You know, that's an ideal situation, an ideal scenario. I think much more frequently, and it's certainly our case that you know that we don't have access to those people, or the need for those people is kind of intermittent or periodic, so it becomes difficult to kind of keep them engaged in our work, kind of in an ongoing way. You know, again, it sounds like kind of a pat answer, but I'll use it anyway. You know, what we've found is that it's less about training and more about sort of a person's mentality. You know, coming from a design perspective. You know, some people that have been trained in things like human factors or industrial design are usually particularly good at having empathy, and that tends to be the primary thing. You know, just approaching things, kind of trying to understand the experience that the person is having. You know, asking more about things that they might say, wanting to go deeper about what the problem is or about those sort of personal experiences. And we found really that those are the places where we get the best information, just, you know, when there's a genuine human interest in the experience that the person has. I'm not sure how you train it. I have the good fortune of working with a few people who are naturally like that. And so those are the people that we get to do that user experience piece primarily.
Yeah, so I mean, I think higher for values, right? Some of that is just deep innate, you know, bringing something to the table, that curiosity. But I feel like all my friends are in the neighborhood today, so we're really privileged. We applied for grant funding for caregiver-centered care. Dr. Jasneet Parmar, Dr. Sharon Anderson, who I know is here with us today, are helping us to train and I hate the word frontline because I feel like those are the people we send over the hill first. So we call them resident-facing caregivers in our environment, and so they are getting that very frontline experience of how do we connect in meaningful ways with our families and recognize the caregiver and the resident as important pieces in our work. And so if we recognize that, you know, this culture shift we've been talking about, where the patient or whatever we're going to call them is at the center of the team, then hopefully intuitively we start to recognize all of the perspectives that need to come together to make this work.
We didn't even prepare that, and curiosity is the exact word that came to my mind. Build a culture of curiosity, because that supports some sensitivity training. I was on one call and the comment was made, oh, I wish we had a patient around the table. And so I made the comment, well, actually, I tick that box as a caregiver for that disease state. And the lady was in healthcare and she said, oh, that's wonderful. Well, I don't think it's very wonderful that I have to manage 16 specialists as one caregiver. It's exhausting. That's one of like 15 hats I wear. It's exhausting. And she kindly sent me and I knew she didn't mean it and it was totally okay, but she kindly realized it and sent me an apology email the next day. But that sensitivity training feeds into that curiosity. And if people are just open and have some pre-conversations and some pre-work with your colleagues that maybe don't work in this space, the meeting can just go that much better.
Great, thank you. Looks like we got a question from Sandy. Go ahead.
Oh, hi there. So me again. So I introduced myself, and I'm here wearing hats. I know Ursula and Heidi both mentioned hats on Imagine Citizens Network. My day job hat, I'm the CEO of the Alberta Dental Association. I'm also a patient who is very engaged in my health and sometimes care. Terminology matters, health and sometimes care. But one thing that I've done in my past career and why I got so involved in Imagine Citizens Network is I've been championing this cause around patient engagement, meaningful patient engagement in healthcare improvement for more than 2 decades. So it pains me a little bit to sit here and to know that we're having this conversation. I've sat on many of these panels around the world talking about the how-tos and the why and the value proposition and how you're going to get return on investment if you're involving patients early on, people with lived experience. So it pains me a little bit, but it also energizes me and excites me because we're having this conversation. We're having a very open and candid conversation about why and the how-to, and we're talking about culture change. So this is culture change. This is progress. It's taken a couple decades, but we're getting there. I'm a little bit feisty, and so when I say culture change takes 2 different forms, it can take 20 years, or it can also, you can force it down somebody's throat. So when I was a senior health executive with a former pan-Canadian health organization, what I did is I challenged my board, challenged my CEO, challenged my team. We're going to establish an internal corporate metric that 100% of our programs, services, offerings are going to be co-designed, co-delivered, implemented, evaluated with patients and families as meaningful and authentic partners at the table. This was, I'm talking like early 2010s. 5 years, we had that as our internal scorecard, and we met it every year. How many health leaders, design, tech folks in this room have something like that where you're transparently influencing culture of your organization because you're making it a corporate objective? Sounds like Heidi probably is. I'm gonna call you out, but that's definitely something I would like this room to think about. So we've had a great conversation. Now we want to get to action. Imagine Citizens all about using information for action. So take it back. What are you going to do differently tomorrow? That's a really important thing when we're thinking about patient engagement. What have you taken away from this amazing panel that you can do differently in your own practices, in your own environment, in your own communities, and get involved. So thank you for the panel for this great discussion. And I just wanted to put a challenge out to the group and to all of you as well. Thanks.
Great, well, thank you. And I know we only have a few minutes, so maybe we'll end on, looking to each of you to respond to that, or give some advice to others to say what can they actually do to incorporate this and build that culture that we talked about. So do you want to start with us?
Sure. I think it starts top down, and I think there have been movements to have people at different organizations added into your personal development plan. And if it's not a personal development plan, it's a personal challenge to reflect and consider how are you going to incorporate it and what does that mean to you, with descriptions and measures and measurements to show those successes and move the needle forward. I appreciate you also said it's very exciting and empowering. It really is. Like, it's not only the right thing to do for an organization and for your business and for the bottom line, it's incredibly rewarding. It's incredibly rewarding and heartfelt to hear what someone's experience is and be able to move the needle forward to make things that much better.
Thank you.
Yeah, this experience is a little surreal to me because it's almost like an arrival of things that have collectively come together over the years, and to be sitting here having this opportunity to speak to this and recognize for the philosophy and the way I do my work. But I would be disingenuous, and there's people in this room, this very room, that have been a part of being thought leaders alongside me and putting those ideas in front of me along the way to be able to embrace. And I know I come to the table with values and that are very clear and to be in service to others, but as we hear ideas along the way, to embrace them. So one of the things that comes to mind is we actually have residents that sit on our interview panels for our staff, and they're involved in our recruitment, because these are the people that are taking care of our residents, and they want to have a voice in that, and they're highly engaged, and they don't even ask to be paid. They love it, and they act and do all kinds of things. So absolutely. I just want to say thank you for acknowledging that it has been part of creating what we've created. It wouldn't be what it is without that journey and partnership with our residents and families along the way. But I also wouldn't be able to do that without being at events like this and having partners in the industry that help bring these ideas to me. So thank you.
Great. Ben?
Yeah, no, thanks for also acknowledging that here we are talking about this topic, and it's almost as if it's a question. There's a little bit that's the answer to the question. Should we have more patient engagement? Well, obviously, and I think we're all unified in that. The little bit that I might be able to add or pick up on in terms of what you just said was that idea of kind of like forcing things upon people, sort of like, rather than going over 20 years or waiting to very incrementally and slowly develop change, to take the opportunity to do that. And the little bit that I might be able to add to this is just to take that opportunity to be tactical sometimes. So rather than necessarily rolling things out across an entire institution or across society or something like that, sometimes smaller interventions or smaller kind of experiments even that push people outside of their comfort zone and how they're working, and force them to sort of consider how else the world might be, can be incredibly valuable as well.
Thanks. And then as a clinician, I want to apologize for any time that we have not engaged patients effectively and efficiently in their own healthcare needs. And I think from my perspective, Sandy, this is kind of tying into you as well. We're so cautious about fragmented healthcare and siloed healthcare, but institutions are siloed as well. And I'm speaking for the Alberta Medical Association, for the Nurses Union, for Alberta Health, whatever. How can we be more intentional about doing things with patients in mind and actively involving patients in everything that we do in order for us not to have that fragmented care? Because at the moment, advocacy is very fragmented, but there's no patients involved in that. That's the first thing. The other thing that I would say is, I've always been, as a healthcare leader, tried to lead by example. So you know what, the example that we set is the example that's going to be followed. And we are at that adoption phase where I think we need to be actively involved with patients and involve them in their care. And how, is there something in particular that I can be part of that can move that dial? And so, for that reason, you know what, whenever I can be at tables and advocate for certain initiatives, I would definitely do that. And then the last thing that I would also say is that how do we as patients, because I'm also one of them, how do we coordinate ourselves in a better way and be that voice and that the political strength that we need to have in order to make system changes? And I would say from a grassroots level up. And how can we learn from examples like Imagines and other organizations in order to organize ourselves better and have appropriate people at tables where they need.
Great. Well, thank you very much. So this has been an absolute pleasure and so much fun getting to know each of you guys. So thank you for not only being here, but for the work that you're doing to continue to make this healthcare system better for us all. So before we call Reg up here, just want to ask that each of you help me thank Ernst, Ben, Heidi, and Ursula for a great discussion today. Over to you, Reg.
Thank you very much, Chris. So folks, when I started off this morning, I kind of said that this was really about us learning. We wanted to learn with the community. So we came to this breakfast with some vulnerability, but curiosity. And we're glad that we have the team around us here to help guide Health Cities as we move into our next level of making changes in the health system. So I want to thank you all individually, but also wanted to recognize the organizations at the table. So first, Ernst from AMA, we have an official collaboration. We really appreciate that. It's wonderful to have the thought leadership of our physicians in our community dealing with the challenges that we have. Ben, Tangent. Tangent Engineering has been a partner of Health Cities for a long time. There's more we can do together, so we need to talk about that. We're glad to have you here. Heidi Canterbury, wonderful organization that's doing some really interesting things, and I think that there's a lot of work we can do together. And of course, there's Love with Patient Voice Partners. You're going to guide us into this world, and it's wonderful. Chris, also for your leadership and helping out with where we're going next in terms of our scaling. And then Sandy with the Imagine Citizens Network also. I think we have a real great team in this room and supporters of Health Cities, and I want to thank you all for being here for the breakfast, but also for your support. So with that, I'd like to thank everybody for coming.